So my name is Benjamin Rawless, and I'm an MD and research fellow in the Mullally Lab in Boston. And we are right now very much interested in TP53 mutations in the context of myeloproliferative neoplasms, so MPNs. So why are we focusing right now on TP53 mutations? I think there are two main reasons. One reason is that there's a lack of data in the context of MPNs. And the second reason is that MPN diseases are chronic diseases. So patients usually live for years or decades without any hopefully bigger problems. But some patients perform really bad, and we are not good to risk stratifying these patients. And because of that, we further focused on TP53 mutations itself. So is TP53 a risk mutation in MPN? Yes, it is. So we presented first data at ASH 2023. Over 900 MPN patients that were treated at the Dana-Farber. And in this cohort, we found 40 MPN patients with a TP53 mutation, and they performed worse. But as always in medicine, it's more difficult as we think, because interestingly, most TP53 mutant patients had also a bone marrow fibrosis. And then we also risk stratified all patients regarding their bone marrow fibrosis status. So patients with primary myelofibrosis and secondary myelofibrosis in the sense of a disease progression. And by doing that, we found out that only TP53 mutant patients with a double hit mutation performed worse, and patients with only a single hit mutation, so only one allele that were mutated, didn't show any difference between compared to patients without a TP53 mutation. And that's completely in line with data from MDS. And how do we define, how did we define TP53 multi-hit mutation? So we said patients have a multi-hit mutation when we had more equal than 2 TP53 mutations that we detected, a variant allele frequency over 50%, or patient that had 1 TP53 mutation and a 70p deletion, or another sign that the second allele was missing in the sense of a loss of heterozygosity. So unfortunately, with the data that we presented at ASH, we were not powered enough. So we had not enough patients to ask the most interesting questions. Due to that fact, we are right now expanding our cohort, and it looks like that currently we will get data from 4 big cancer centers in the region of North America. So that's amazing. And we plan to ask important questions to further risk stratify and better deal with TP53 mutant patients. So, for example, there's also the question, what cause a higher mortality in patients with a TP53 mutation? And that's a very important question. So some of these patients develop secondary AML. In our cohort, we found about 30% of patients that developed secondary AML, but there will also be a higher number that we don't know of. So people that maybe developed secondary AML, but it is not reported. And then we also ask ourselves if maybe some of these patients die from cardiovascular risks or other reasons. And that's one of the questions we would like to further investigate. And we are also very much interested in the single hit patients in our clinics. So why do some of these single hit patients perform very bad? So most of them perform quite good, but some of them perform very bad compared to multi-hit patients. And then we are now asking the questions in our data sets if that's maybe due to double hit mutations that these patients acquire at a later time point, or is that the reason that some of these patients that we claim as single hit patients have small clones that have a multi-hit mutations, and we are just not able to detect this mutation? Because of that, we try to address it with single cell techniques now, or are other mutations responsible to that? For example, mutations in PPM1D. or is maybe, and I think that's right now in the field, a lot of people are interested in that, is maybe also chronic inflammation one of the factors that can drive disease progression, maybe also the acquisition of a double hit TP53 mutations. So these are a lot of questions that we try to address in future studies, and because of that we are expanding the cohort, and the overall goal is then to really build a risk score and to make a maybe make a very dramatic scenario. So for example, when a young patient comes to your clinic and with the first diagnosis of MPN, and you detected TP53 mutation, and maybe it's a single hit mutation, then we want to know how we have to address this mutation. And right now we are, there is a high need of kind of a better risk stratification for these kind of patients. So is that a patient that has a TP53 mutation but lives for years or decades without any problems? Or is it one of these patients that progress very fast and develop maybe secondary leukemia, and we have to treat these patient early and very aggressively, maybe with an early stem cell transplant? And these are questions that are unsolved in the field. At least we think that, and that's something we would like to work on, and we are currently working on that, and to build to build a guidance for clinicians to to hopefully better deal with these kind of patients, and to improve the overall treatment for TP53 mutant patients.